Hello friends, this is a case of robotic fundoplication. So we can see we have put a bougie right now, that is 36 French, and left hand has a atraumatic grasper and right hand has a mega needle holder with the scissors. So here we are asking our assistant to just use ligature and little bit cut the peritoneum so that we can start the blunt dissection. And this mega needle holder is holding the peritoneum just lateral to the caudate lobe and above the pars flaccida. So this is a small window has been made in the pars flaccida, and this is the lateral mobilization and posterior mobilization of the esophagus with the blunt mobilization. Here we are using the needle holder itself as a grasper, and left hand has a atraumatic grasper which is giving the anterior traction to the esophagus. So this is the posterior mobilization of the esophagus in order to make a retroesophageal tunnel so that we can bring the stomach for the wrap, and this is all blunt dissection. So left hand atraumatic grasper is lifting the esophagus anteriorly, and slowly blunt dissection is making the posterior mobilization of the esophagus. Here assistant is ready with the ligature. So if some oozing happen, he can control it and he can coagulate it. So this all is going on blunt dissection. Here we can see again assistant is, this is we are using laparoscopic port for the ligature. And this is just over the right crust. This peritoneum is getting separated. You can see the caudate lobe of the liver is also visible. And now this is the anterior mobilization. So this instrument is a mega needle holder with the scissors. In this instrument, the tip has a needle holder and the base has the scissors. So this is the anterior mobilization. Now again assistant can coagulate and cut this peritoneum anterior to the esophagus. So that way we don't have to use a Maryland dissector and we don't have to use a bipolar or scissors. of robotics. So, just a small little help of the assistant will prevent you using two extra instrument. Now, this is the lateral mobilization on the left side. Again, this is anterior mobilization. We can see the left crust is clearly visible and peritoneum over the left crust is getting separated. So, this is again ligature to coagulate and cut the peritoneum over the left crust. So, this part is over. After that, we will cut some of the short gastrics over the fundus, and that also we need help of the assistant, or if you want to do it effectively, you can use your own robotic harmonic, or you can use robotic bipolar or seizures. But here the entire surgery we will perform only by two robotic instrument, so it will be very cost effective. So, minimum 10 centimeter of the esophagus, the stomach has to be mobilized so that you can have a floppy fundus, and then you can have the floppy nition. Behind this we have a spleen which is clearly visible. Ligature is a very good vessel sealer. So, if you use for that, there will be absolutely no bleeding. But any traction should must be avoided. So, this part is over because we can see we can mobilize it is a mobilized stomach, because the left hand is giving the medial traction and it is almost reaching up to the caudate lobe of the liver. We have to be careful here because just above is the spleen. However, good thing about the ligature is that even if tip will touch the spleen, it will not do any cutting effect because the blade doesn't go beyond the tip of the ligature. So again we are seeing the posterior window is proper or not, and then this window will be further enlarged. So this we can see this window is there, and now it has to be sufficiently enlarged so that stomach can be taken from behind, and it should be without any tension. You may apply a sling here, or we use in the laparoscopy, we use the gold finger forceps to hook it behind. Here we are anterior to the left crust, as you can clearly see. And just this little peritoneum is remaining, which can be clearly opened. We have to be careful that diaphragm should also not get injured, and accidentally a spleen also should not get injured. So we should do completely blunt dissection. Here it is the transparent part, what you are seeing is a stomach. And now this window is formed. After that you can enlarge little bit, and the stomach, the wrap can be taken from the left to the right. And posterior wall of the fundus will be pulled. Now you can check for the shoe shine, and it's look good. That much will be sufficient and it will do the job. So now we have to do crural approximation. We can see the after the mobilization of the crust, crural approximation is important. So we are using ethibond suture here for the crural approximation. Assistant is giving little traction. So lifting the esophagus anteriorly, and then you can safely take the bite. This is the left crust. and here is the right crust. Care should be taken that you should not go below the caudate lobe, otherwise vena cava can be pricked. So, this is the second bite. And then the surgeon's knot will be tightened. This has a seizure that will cut the suture as well. Now, we will take one more bite on anteriorly to fix the stomach, but that we will do later. So, now the next step is that the stomach will be pulled again. And then plicating suture will start. A little oozing was there. This is little muscle of the esophagus, and this is basically the distal knot. Proximal we will do later. Now, the second knot will be taken towards the diaphragm, and again stomach to stomach. Little muscle superficial of the esophagus. If it is sleeping, you can ask your assistant to hold. Otherwise, you can use tumble square knot. Now, assistant will remove the needle and suture by dropping one needle holder. That is laparoscopic needle holder, because the robot, as we know, cannot take the tissue out, cannot take the needle out, cannot drop the needle in as well. And now the assistant will take these sutures and as well as needle, and he will take it out. Now we have a new suture and we have to fix the stomach with the anterior crust also, because there is a small back, so that gastropexy will help it. However, this step is optional. We can see suture is good, it is not loose and it is not tight as well. So, it is optimum. So, this is the third bite. Only a stomach to a stomach. There is no need of this bite to take the esophagus. And esophagus is getting sandwiched in between the two stomach layer. Now you can see there we have little gap. So, we will fix the stomach there. So, this is taking the bite on the right crust. As well as bite in the stomach. And then this is the on the left wrap of the stomach. So, it will fix the stomach with the diaphragm. And it will decrease that opening also. It is very important that crural approximation should not be very tight, because that is one of the cause of the dysphagia. So it is done. Now bleeding hemostasis will be checked. Needle assistant is pulling out. We can lift the stomach little to see that it is posteriorly, it is not very tight. So it's fine. No bleeding and no tight crura. Posteriorly also it is good. Little opening of 5 mm between, it is good. It should not be over tightened. And now the Nathanson lever retractor will be taken out. So assistant will gently take the Nathanson lever retractor out. So thank you very much for watching this video. This was just a robotic fundoplication. Have a nice day.